Good afternoon, everyone. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to all the respected dignitaries and faculty for today's event. Today's theme is key issues in obstetrics and gynecology. We have two wonderful speakers. One is Dr. Supriya Arwari. She is a chairperson of AMOG's, and we are privileged to have Dr. Sonia Malik today with us, past president of IFS. Both of these distinguished stalwarts will be talking to us on two very important issues in OBGYN. But before we start the event, I'd like to start by expressing my gratitude to our AMOG's president, Dr. Nandita Palshetkar, current president of AMOG's, immediate past president of FOXY, also a past president of the Mumbai Society and IAG. Thank you so much for your guidance, your blessings, and for always being there to support, promote, and encourage all of us who are following in your footsteps. Thank you so much, ma'am. I'd also like to place on record my gratitude to Dr. Arun Nayak, our Secretary of AMOG's. Sir is also a past president of the Mumbai Society, extensively trained abroad and very much a distinguished academician in his own right. Next slide, please. At this point, I'd like to express my gratitude to the Chairperson of ICOG, Dr. Mandakini Megh, and the Secretary of ICOG, Dr. Parag Biniwale. Thank you so much, Madam and Sir, for granting us ICOG credit points for all of our events so far, including today's event, which has been accredited with one ICOG credit point. We have two very fantastic chairpersons who are here today. Both are office bearers of AMOG's. And the first is none other than Dr. Kiran Kurtakoti, sir. Sir is the second vice president of AMOG's. In the past, he's been chairperson for the MTP committee of AMOG's, chairperson for medical education, research and training, and also served as the second joint secretary of AMOG's way back in 2009. Sir was the chairperson for the FOXY MTP committee and has organized several conferences and important events for AMOG's in the past. Thank you so much for joining us, sir. It's lovely to have you again with us. Next slide, please. The second chairperson is none other than my dear friend and colleague, Dr. Amey Purandare, sir. Sir is a consultant OBGYN at several hospitals throughout Mumbai. He was joint secretary of FOXY in 2019, chairperson for the Food, Drugs and Medico-Surgical Equipment Committee of FOXY from 2015 to 17. He's currently the assistant administrator for the FOXY Manyata project on quality care in safe childbirth, a member of the managing committee of the Mumbai Society, mentor for the Youth Council of MOGS, and has served in several distinguished roles for AMOG's, including the honorary secretary of AMOG's, the zonal coordinator, and now currently he's the state coordinator of AMOG's. Sir is contesting for the post of vice president of AMOG's this year, and we wish to see him in not only the vice president post, but in several other posts in many organizations, of course, including AMOG's and FOXY. It's really lovely to welcome Dr. Amey Purandare back with us. Last week when Dr. Archana Verma was here, she was missing him, and promptly Amey is there in the next event. He's here with us. So before I hand over the proceedings to the chairpersons, I would request Dr. Kiran Kurtakoti, sir, to please brief us about the upcoming AMOG's conference, which is due to be held in June, and then we can have the introduction of our first speaker, Dr. Supriya Arwari. Sir, please unmute yourself.
Thank you, Dr. Pratik, for allowing me to say something about the AMOG's conference. At the outset, welcome all of you on behalf of AMOG's fraternity, and thank you, Pratik, for bridging the gap in a true sense, because we have a very distinguished speaker in form of Dr. Supriya, who is our AMOG's fraternity, as well as Dr. Sonia Malik, who is from outside Maharashtra. So before we get on with the function, we all know that right now, because of COVID times, we are stuck to this webinars. And however, we look forward to see each other in person, crack jokes, listen to the academics, and of course, enjoy the gala evenings. So to invite you on behalf of Dr. Nandita Palshetkar, Arun, myself, Dr. Pardesi sir, we have decided to hold a physical conference on 11th, 12th, and 13th of June this year at the 7-star hotel Ritz-Carlton in Pune. It is very close to the airport. So those of you who are from Pune or from in Maharashtra, of course, can come down. But those outside Maharashtra also can fly in, and to the airport. It is very near to the airport. We have planned a very fantastic scientific program. The theme of the conference is critical care in obstetrics, which is a very dear topic to all of us. And so please looking forward to meet you all in person for this conference. I think that's all from my side. We have two very distinguished speakers. May I request the organizers to please share the screen? Share the biodata of Dr. Supriya. Thank you. Supriya is a very dear friend of mine, and she is one of the most active members of AMOS fraternity. And Supriya, along with Chaitanya and Alka, will be very much there for this AMOS conference, and they will be doing the cultural event, the other skits for all of us. So Dr. Supriya, she's a consultant infertility specialist practicing in Thane for the past 20 years. She is an alumni of the prestigious KM Hospital, Mumbai, and the GS Medical College, Mumbai. She is the joint treasurer and the chairperson of the Adolescent Health Committee of Thane OBGY Society. She is the past president of IMA Bhiwandi and Bhiwandi Medical Practitioner Associations. She is the founder chairperson of the IMA Bhiwandi Women's Wing, ex-co-chairperson for the state committee of the PCPNDT. She is a gold medalist at the DGO and FCPS exams. She is, of course, the awardee for the meritorious service by female doctors. She has received the Dr. Anandibai Joshi Award. She is the organizing chairperson of the annual academic event or the Mega CNE of IMA. She is the ex-person of the Internal Complaints Committee of Torrent Power Bhiwandi. She has won the title of Mrs. Iron Lady at MedicWin. So that's a thing with Supriya we didn't know about you. So although she has won the title of Iron Lady, Supriya is one of the most gentle ladies as far as Amox and Fox is concerned. So Supriya, please, we look forward to your presentation on how to improve the fetal outcomes in Rh negative pregnancies. Supriya, the stage is yours. Yeah. And of course, at the outset, and as Pratik rightly said, a warm welcome to my co-chairperson, Dr. Amya Purandare. Amya, we wish, hope, pray that you are elected unopposed to the post of president of AMOS or vice president of AMOS. Yeah. So please, Supriya, the stage is yours.
Yeah. Thank you so much.
Thank you, Kiran, for your kind word. Before Supriya starts, it's a great pleasure to be chairing this session for when Dr. Supriya Arwari is speaking, because Dr. Pratik and me, we both worked as students, interns, and residents under Dr. Supriya in our grand Wadia days. And Supriya inculcated a lot of good habits amongst us as far as clinical care is concerned. So it's indeed it's a great privilege to be chairing this session, and looking forward to hearing from you, Supriya.
Thank you so much, dear Kiran, for all those sweet words. Thank you, Ameya and Pratik, of course. And you cannot even imagine how humbled as well as honored I feel when you call me your teacher or your senior. And I'm so glad that my juniors have gone all this way in life, that now, we look up to them and draw inspiration from the kind of work they're doing. So at the outset, I'd like to thank the president of AMOX, Dr. Nandita Palshetkar, the secretary, Dr. Arun Nayak, and the entire team of AMOX, and especially Pratik for allowing me to be a part of this CME. And the topic given to me is about RS isoimmunization. So without much ado, I think I'll start my screen share. And I will again thank Pratik for all the academic inputs that I have received from him. Thank you, Pratik. Made my job a lot easier. Okay. Are my slides visible though? My slides are visible?
Yes, ma'am.
Okay. So we are going to talk about improving fetal outcomes in Rh negative pregnancies. Particularly, we know that Rh negativity is not something that we see every day, but when we see it, we really see it. And that's why this is a topic which is so very important. Now, to give you a brief history of how the blood groups were discovered, most of us know about it. The first big major breakthrough was done in 1901 when Karl Landsteiner described the ABO system of blood typing. We all know about it. The second major breakthrough came in the 1940s, at 1940-41, when Landsteiner and Alexander Weiner discovered the Rh blood type. Okay, and the next most important breakthrough came in none other than 1977 in our own very country and in Amchi, Mumbai, where Manmohan Desai and his team made Anhoni Ko Honi, and he allowed us to discover that खून खून होता है, पानी नहीं, लेकिन पानी जैसे किसी का भी खून किसी को भी चढ़ाया जा सकता है. Thankfully, science has made a lot of great strides in the field of human blood grouping and typing, and luckily we have left behind all these pictures of a common thread of blood going, and 2-3 people are giving their blood for donation without any typing whatsoever, without any testing being transfused in the mother. So let me now go to my topic as such. So this is just a brief outline of what I'm going to be speaking on today. What about the disease burden? Like I mentioned, Rh negativity is in today's times especially is not something that we see every day, but when we see it, it's really bad. So if we talk about the 210 statistics, you can see 373, more than 3 lakh babies are affected worldwide. Now that is a really big figure. From the global prevalence of Rh disease, if we see, the rough figures are around 276 per 100,000 live births. That is again a very significant figure. 80% of babies born to Rh negative mothers or who suffer from Rh disease and extreme hyperbilirubinemia are usually in countries where the neonatal mortality is high. In short, the developing countries who are still struggling with a very high rate of neonatal mortality and morbidity are also the ones who are struggling with Rh alloimmunization disease. Neonatal deaths due to Rh disease can be as high as 24%, which is again a very significant number. More than 50% of Rh alloimmunized babies are going to be suffering from kernicterus. Now that again is a very dreaded complication that we would definitely like to avoid in neonates. And 7.2% of all Rh disease affected who survive will develop kernicterus and have to live with the effects of kernicterus in future. Stillbirth and neonatal death rate, this now you can see this chart about the Southeast Asian countries and South Asian countries, and it is really so sad that South Asia is leading the world with cases of Rh immunization, and mainly countries like ours, like Afghanistan, we are still struggling with a lot of Rh isoimmunization, and the burden of the disease on our country in particular is very high. Now, this is just a state-wise distribution, or you can say prevalence of the disease. And for some strange reason, the northern states like Himachal Pradesh or Uttaranchal, these states have recorded a very high, positivity. Rather high number of Rh negative population. Now, when I was studying the history of Rh groups or rather ABO groups, when Karl Landsteiner first discovered the groups, according to him, O positive is very common in the races which are the oldest in the world, like the African races where humanity really is thought to begin, and then the other blood groups came in. So A positive is among the comparatively newer countries or newer populations, like say in the European countries or in the Americas, where later on people migrated and settled. Now, basically pathophysiology, to know about it, we should know basic classification. Now we know that what Landsteiner has discovered is there are two major systems according to which we classify all the human blood types. One is the ABO system, or the major blood group system, and the other one is the rhesus system. The ABO system Landsteiner first described in 1901, and later in 1940-41 he talked about the rhesus system, wherein he injected the serum in rhesus monkeys and had certain findings, and therefore the name Rh was allotted to this particular group of people who have this Rh or rather the D positive genes. In the ABO system, we all know there is A, there is B, there is AB, and then there is the O. In the rhesus system, we have a capital C and a small c. We have a capital D. We have a capital E and a small e and a capital G. Now, capital D is the most important of the various markers of the RH system, because that is the one that creates the maximum number of iso or alloimmunization. Now, D and small d, for description sake, we use. However, small d does not mean that there is any particular recessive gene. It just purely means there is absence of capital D. Okay, and that is the most immunogenic gene that is there, the factor, and therefore we give maximum importance to the D factor. This is a chart which shows what kind of progeny an Rh negative mother who breeds with an Rh positive father can expect. Now, if the father is a homozygous, means he has both positive copies, then it is possible that she is going to have 50% of positive kids and 50% Rh negative kids. Sorry, I take my words back. If it is a homozygous father where he is having both capital genes, capital D, then all the children are going to be Rh positive. However, there is a likelihood that all the children are going to be heterozygous positive, Rh positive. However, if the father is heterozygous and the mother is a non-Rh negative, then around 50% of the kids are likely to be Rh negative. Apart from this, the father and mother both may be Rh positive, but if both are heterozygous Rh positive, then there's 25% chance that the progeny will be Rh negative. What are we basically worried about when we talk about Rh incompatibility? Basically, there is feto-maternal hemorrhage that takes place. That is, the fetal blood cells, they go into the maternal circulation, and the maternal circulation then reacts to the Rh cells because she is Rh negative and certain Rh positive cells come into her circulation. The amount of fetal blood necessary to produce an Rh incompatibility is going to vary a lot. But it can be as little as 0.1 ml of Rh positive cells, which can cause a reaction in a mother. Studies have suggested that up to 30% of people with Rh negative blood type, even if they are Rh negative, will still never develop antibodies to an Rh positive challenge. So they are the non-responders. In spite of being Rh negative, whatever kind of load they get of Rh positive blood, they are not going to create a reaction to it. However, 70% of the remaining population, the 70% are going to give some kind of reaction or the other. Now, Rh alloimmunization occurs by one of the two mechanisms. That is, first, it means that there is some introduction of Rh positive blood cells into an Rh negative individual, and this can take place, number one, if she has had an incompatible blood transfusion in the past, or secondly, when there is a feto-maternal hemorrhage between the Rh negative mother and an Rh positive fetus during pregnancy. Feto-maternal hemorrhage may occur during pregnancy. It can occur antenatally, that is 10%, but majority of the transfer is in the postnatal period. That is 90% of the hemorrhage is going to take place immediately after delivery till maybe the delivery of the placenta. Notwithstanding these figures, fetal RBCs have been detected in maternal blood in all 3 trimesters. So there is no particular time where you can be so sure that there is going to be no a flow of fetal blood into the maternal circulation. It can happen during all 3 trimesters of pregnancy, and that is why the current thinking is that once an Rh negative mother presents to us, we will not wait for a certain trimester or a certain week of gestation to get her investigated. The first thing at first contact is that we would like to get her tested for Rh antibodies. The initial maternal response to Rh sensitization is low. We all know that in the first phase, when the hemorrhage of, rather the transfer of Rh positive fetal cells into the maternal circulation, the mother will first create IgM antibodies. Now, these are larger antibodies. They are produced in lower levels, and they do not cross the placental barrier. So the initial response of IgM antibodies is the one that is, immediate reaction. However, they are not going to cross the placental barrier. Later, within say 6 months to a period of 6 weeks to 6 months, the IgG antibodies start getting formed, and these are the troublemaker antibodies, because number one, they're smaller in size, molecular weight is lower, so they cross the placenta. Secondly, they're going to be created in a larger number. Titers are going to be higher. They are able to cross the placenta. Therefore, they'll go into the fetal circulation and they'll start destroying the fetal Rh positive cells. Obviously, because Rh negative mother produces antibodies to Rh positive fetal cells. Those Rh antibodies get transfused into the baby during the placental circulation, and then they start destroying the baby's Rh positive cell. Therefore, firstborn infants of Rh positive mothers will be not affected or very mildly affected, because the initial response of antibodies is IgM, which is not going to cross the fetal-placental barrier, and the majority transfer is going to take place after the first baby is born. So the major chunk of antibodies is also going to be manufactured in the mother's blood after the first baby is born. So that is the reason why the first baby is usually spared of Rh alloimmunization, the results of it. Now we'll talk about the hemolytic disease of newborn. So second baby onwards, if this mother is isoimmunized, then there is a likelihood that the baby will face certain consequences of the reaction that the mother has created. Now, what are these? The maternal IgG enters the fetal circulation via the placenta. Now, this can occur from the first trimester onwards. There is destruction of the fetal red blood cells. So consequently, there is fetal anemia. We would like to keep a hematocrit of the fetus above 30%. So any hematocrit less than 30% is definitely a sign that the baby is suffering from fetal anemia. The heme that is formed by destroying the RBCs is then converted to bilirubin. So that causes fetal hyperbilirubinemia. Now, both though the fetal hyperbilirubinemia can be neurotoxic to the baby, however, till the baby is in utero, the placenta is going to clear it for him or her, for the baby, and metabolize it. So the mother is going to metabolize the bilirubin, and therefore probably the signs of fetal hyperbilirubinemia will not be evident intrauterine. However, signs of fetal anemia are definitely going to be evident intrauterine. Okay. Also, because the baby is suffering from chronic anemia, so extramedullary erythropoiesis is stimulated, and this causes a lot of immature erythroblasts coming into the fetal circulation. When the cell destruction exceeds the production, now there is going to be a time when the cells are being destroyed. However, the baby is able to produce cells to replace the cells that are destroyed. However, when critical level is exceeded and where the baby can no longer maintain the equilibrium between cell destruction and cell production, that is when the baby is going to start suffering. So first and foremost, we can have severe anemia in the baby. So there is more, like I already mentioned, there's more demand on the extramedullary sides. They'll start producing more red blood cells, and that can consequently lead to hepatosplenomegaly in the baby. With anemia, the consequential hyperdynamic circulation is going to lead to heart failure in the baby. So we can have ascites, we can have edema, we can have pericardial effusion. In short, what we call as hydrops is going to develop in this baby, hydrops fetalis, which basically means the baby is retaining a lot of fluid, which is getting collected in all the extravascular compartments of the fetus. And this will happen usually once the hematocrit falls below 15%. And often hydrops is one of the markers that this baby is headed towards imminent death. Now, statistically, it has been seen that male fetuses are much more prone to Rh alloimmunization compared to female fetuses. I believe society has not been kind to women, but God has been kind to women, and we know that female fetuses are gifted in certain ways. They are stronger, they are more resilient, and I believe this is one more thing that adds on in favor of the women. What I was talking about in the past 2 slides, this is just a schematic description of what is going to happen in a mother who is, looks like a very busy slide. However, it shows basically the same thing. The first pregnancy, there is going to be some amount of transfer of Rh positive cells into the mother. The mother creates antibodies. However, the first baby is saved or spared of the side effects. However, when the baby has when she has the second baby, and that baby too is an Rh positive baby, that is when the antibodies that are already present, the IgG antibodies, are going to enter the maternal, from the maternal to the fetal circulation, and create havoc. Rh sensitization risk compared to the general population, risk and severity of the sensitization increases with each number of subsequent pregnancies where there is an incompatible fetus. So if say at the first baby is Rh negative, she has a certain risk of developing this risk attached to Rh sensitivity. It will go on increasing beyond say, second or third baby if repeatedly she has positive baby, and without prophylaxis, the risk is around 16% after 2 deliveries. So we can see 16% is quite a significant amount. And of these, 1.5 to 2% will occur in the antepartum period. We already know that only 10% of the main isoimmunization takes place in the first in the antenatal period. 7%, that means 90% of them who are affected are going to be affected post-delivery within 6 months of the delivery, and 7% of them will manifest early in the second pregnancy because now she's already created antibodies in her body. With prophylaxis, now this is what is most important, and probably the bottom line of this lecture here is that with prophylaxis, the risk is going to drop to 0.1%, from 16% to 0.1%. That is a very, very dramatic and significant drop. The aforesaid risk depends on 3 main factors. Obviously, that is the volume of the transplacental hemorrhage. Okay. Secondly, extent of the maternal response. We already described that there are some non-responders. 30% women are not going to create antibodies in spite of a Rh positive insult on their blood. And concurrent presence of ABO incompatibility. Now, if there is ABO incompatibility, the cells are going to be destroyed by the major blood groups, and that probably gives a protective risk against the Rh isoimmunization component. So if the baby is ABO incompatible with the mother, once the baby cells enter the mother's cells, they'll probably get destroyed because of the ABO incompatibility, and there will be no RBC, the fetal RBCs remaining behind to create an Rh response. Rh incompatibility is only of medical concern for females who are pregnant or to plan a pregnancy in future. Okay, so somebody who has completed her childbearing would probably not be the one who will be concerned about this Rh sensitization risk. Now we come to the most important part, that is management, wherein we'll go with the history, the examination, the investigation, and then what are the treatment options. Now, first and foremost, history is most important. We all know that patients tend to hide their history for reasons best known to them. Many times they feel it's not significant to tell about previous abortions, but we know that a detailed history is imperative, especially whether she has had abortions and whether she has taken any prophylaxis post-abortion, whether she has had any invasive procedures in the past like amniocentesis, coronal villus sampling, whether she has had any abdominal or pelvic trauma, whether she's had antepartum hemorrhage like placenta previa or abruptio in the previous pregnancies, an intrauterine demise in the previous pregnancies, multiple gestations, MRP. So basically an ectopic pregnancy, cesarean delivery, basically any event which can trigger a higher amount of maternal and fetal blood reaction, wherein more amount of fetal blood is pushed into the maternal circulation. So any of these events we should know. The other parts of the history that we need to know is whether she has received any blood transfusion in the past. It is likely that she has had some incompatible blood given in the past, which was a mild. She had a mild reaction. However, she managed to create some Rh antibodies, and those can give trouble. Now, once we know that the mother is Rh negative, the first and most important thing that we would next like to do is get the patient's husband's blood type. Okay. Now, if the spouse is Rh negative too, the last thing we would be bothered about is an RH incompatibility. However, if the husband is RH positive, then we would definitely be on the lookout for RH alloimmunization. All previous pregnancy outcomes and interventions should be known to us. Whether there is a history of previously affected baby, either hydrops or neonatal jaundice or neonatal hyperbilirubinemia, because these women are as high as a 90% chance of recurrence, which is very, very, very significant. Okay. Previous administration of RH antibodies, whether she has had any IgG, immunoglobulins given to her in the past. If she has had history of maternal trauma in previous pregnancy or during this pregnancy, whether it was a severe trauma, whether it was followed by an ultrasound, whether it was, it resulted in some bleeding per vaginum. So all these histories, and of course, whether any prior invasive procedure was done. The basic objective of the management is, number one, primary prevention. So we try to avoid RH alloimmunization altogether, if possible, in an RH negative unsensitized woman. And secondly, if at all we cannot prevent, then secondary prevention, or you can say secondary treatment, that is early detection and treatment of the fetal anemia, or try to avoid the complications, or at least reduce the severity of complications in the fetus, and try to take the fetus as close to term as possible before we deliver the baby. So sensitization is determined via the Coombs, indirect Coombs test, otherwise called as the antibody screen, or what we call as the RH antibody titer. Now, there was a time when we used to say at 16 weeks, at 24 weeks, at 28 weeks. But now the current thinking is, as soon as the patient presents to you and you know that she is RH negative, first and foremost, get her RH titers done. Now, what are the special precautions that we would like to take during delivery so that we can go ahead with, number one, primary prevention? Okay. Now we know she's an RH negative mother. She's come for the first time to deliver. And we know that this baby may not be at a great risk, but we want to prevent or mitigate the complications that can take place in the next pregnancy. So to ensure that the load of fetal cells circulating into the mother or getting pushed into the mother's circulation is low, first and foremost, at the time of delivery, of course, we like our neonatologist to be on call to check the baby as soon as the baby is out. Avoid giving oxytocics before the placenta is delivered. Often we give oxytocics as soon as the baby's anterior shoulder is delivered. However, in these cases, we would like to delay the oxytocics to at least till the baby is delivered and the placenta starts separating. That is probably the time when we would like to give the oxytocics. Try to avoid MRP as far as possible, obviously, but if we have to do it a little gently so that the load of fetal cells going into the maternal cells can be reduced to a minimum. If at all transfusion is required for the mother, please make sure RH negative blood only and only is transfused in any woman for that matter, or any human being for that matter. Early clamping of the cord is indicated so that we reduce the transfer of fetal cells back into the maternal circulation, and leave a good length of cord with the baby, like say around 15 to 20 centimeters, so that God forbid if the baby lands up with some trouble, at least we have a good length of cord which can help us give either cord transfusions or exchange transfusions. Postpartum management again involve the neonatologist, get the baby's sample for ABO and RH typing, baseline bilirubin level, maybe a peripheral smear. If the baby is RH negative, nothing further to be done. If the baby is RH positive, however, we have to determine the dose and when to give it. Okay. What comes next is the 4-step laboratory procedure. Now, for completion's sake, I'll mention it here. But most of us don't do all this, and we give anti-D to the mother if the baby turns out to be RH positive. Okay. However, to complete the list, this is the 4-step process how we can calculate or find out how much is the dose of the RH antibody to be given to the mother. So this, I'm sorry, this dose will help us to calculate for the baby if the baby requires RH antibodies. So the Rosette fetal RBC screen, acid elution, estimate the volume of the fetal-maternal hemorrhage. That is done by this formula of 50 multiplied by percentage of fetal RBCs, and thereby calculate the dose of the rhIgG to be given to the baby within 72 hours of birth. These are the tests. Now, for sensitized women, what should we be doing for women who are already sensitized? We talked about a woman who's come for the first time. We do her Rh test. If she is negative, we do her antibodies. If the antibodies are negative, we just leave her alone. We check the baby at birth, see the baby's blood group, and if baby is Rh positive, we give her injection anti-D. If baby is Rh negative, nothing more to be done. We can, however, add I'm going to talk about those, the antenatal injection of anti-D. I'll just talk to it in a few slides later. For the sensitized woman, what are the guidelines for management? Presence or absence of history of an affected fetus, most important, because 90% of, if she's affected in the previous pregnancy, then 90% chance that she's going to develop fetal hydrops and anemia. Maternal antibody titers, even if there is no prior history of transfusion or any other positive history, still we should check her antibody titers at the first visit. Don't wait for any particular time of gestation. Sensitization may be determined by doing the antibody screen, that is the indirect Coombs test. Okay. Now this is just a slide, technical slide, which shows how the direct Coombs test and the indirect Coombs test is done. What we prefer is the indirect Coombs test. This is the important part that we are to deal with. That is the anti-D prophylaxis guidelines. We have a woman who's come to us. She's delivered. It was the first baby, and now the baby's turned out to be Rh positive. What do? Of course, we will be giving her injection anti-D. Now, injection anti-D is an antibody against the D epitope of the Rh of which is present on the fetal RBC, okay, of a fetus who is Rh positive. And to prevent the Rh negative woman from getting sensitized, we will give her this shot of antibody, that is anti-D. What is the mechanism of action? The anti-D immunoglobulin is given injected. It's a ready-made immunoglobulin. You just give it by intramuscular injection. It will enter the mother circulation and it will coat the D epitope of the fetal RBCs that are present in the maternal circulation, and thereby prevent the interaction of that D epitope with the maternal circulation, whereby the antibodies that can subsequently develop to that D epitope will be prevented. Okay, and the consensus on the dose is that 300 microgram of anti-D neutralizes as much as 30 ml of fetal Rh positive blood. So that is equivalent to 15 ml of packed RBCs. A usual transfer of fetal blood is much less than this, around 5 ml, 7 ml. So if we have a dose which covers 30 ml, we are fairly assured that majority of the RBCs are going to be rendered inactive in the mother's circulation, and the mother therefore will not develop antibodies to the fetal Rh positive RBCs. The monoclonal antibodies, they are highly specific. They are against various single antigenic epitope produced by the clone of a single hybrid cell formed in the laboratory. The advantages is that very specific, consistent and uniform, and it is safe as far as transmission of viruses are concerned through the anti-D preparation. The polyclonal are derived from sera of several immunized human beings and therefore made up of a mixture of antibodies. So they cover a wide variety of antigenic epitopes, but difficult to manufacture in large quantities. Batch to batch inconsistency is very likely, and there is a high chance of injection of the harmful proteins. Now, these are the guidelines for prophylaxis given by various organizations from ACOG, RCOG, FOXY, and you will notice that the consensus is definitely there that any Rh negative woman who delivers an Rh positive baby has to have 300 micrograms of anti-D injected within 72 hours of birth. So you can see the first column. All the organizations have a consensus as far as this is concerned. So there is no two ways about giving anti-D prophylaxis in a woman who has just delivered, RH negative woman who has delivered an RH positive baby, and within 72 hours of delivery, so that we can get maximum response. What are the sensitizing events that you would normally be looking for? Now, other than a full-term delivery, say she has a abortion at less than 12 weeks, there the recommendations are varied. But if we talk practically, I feel at least in most of India, either 300 microgram or 150 microgram are the two available strengths. So if she is less than 12 weeks, okay, now if we go through the guidelines, see less than 12 weeks, the dose is 50 to 120 microgram. Now I really am not sure whether 50 microgram is available in India at all. And above 12 weeks, the entire dose of 300 microgram. I think we should stick to less than 12 weeks, 150 microgram, more than 12 weeks, give the full shot of 300 micrograms, because most of the organizations are, recommending that. Now, how do we manage an RH sensitized woman? Now, woman is already RH negative, we know, and she's already sensitized. How do we go about her? First and foremost, we'll take the history. If the mother is sensitized, but she does not have a previously affected fetus, okay, we will first obtain obviously the RH group of the husband, ABO, as well as RH typing. Now the mother is, the husband is RH negative, nothing further needs to be done. If the husband is RH positive, what next? First, we will first be checking the antibody levels of the mother. Now here, the antibodies should be checked first and foremost at first point of contact, that is whenever she comes to register. If the antibodies are negative at that point, antibody titer is negative, then maybe at 34 to 36 weeks, we will repeat those titers. If they are still negative, the mother is safe. We deliver her, check the baby's blood group. If baby is positive, give her anti-D. If at any point of time, the titers of the antibody turn positive, if she comes with a positive antibody titer, then every 4 weeks, at least 2 to 4 weeks, we would like to repeat her titers and try to monitor the baby closely, so that we can find out at what stage the baby is getting affected, try to mitigate the complications of alloimmunization, and try to prolong the pregnancy to as close as term as possible. Okay, so first visit, RH titers, indirect Coombs test. If negative, if at first visit RH negative mother, RH positive husband, the Coombs test is negative, repeat at 24 to 28 weeks. Next repeat at 36 weeks. If negative, just give her an anti-D after birth. If at any point of time the RH titers turn positive, then we have to repeat 4 weekly. Repeat the titers 4 weekly. If they start rising, we may have to do it more frequently, and 1 in 20 or 1 in 24 would be the critical level when we would actually think of doing an amniocentesis on that mother to find out whether the baby is getting affected badly. Okay. Now, if positive, this is what I have just mentioned, this left side of the column. So if the antibody titer is still below the critical level at 36 weeks, continue the pregnancy, but don't allow her to go to term. Deliver her at around 37, 38 weeks. If obstetric indications are fine, we can even think of inducing her and allow her a vaginal birth. If at any point of time before 34th week, the critical levels start increasing, then what do we do? If she's already 34 weeks and antibody levels reach the critical level, again, we may think of delivering her early. But if she is less than 34 weeks, then there are certain investigative modalities which are a must. The basic aim is to find out how much is the fetal anemia, and accordingly either treat the baby or observe the baby, as the case may be. Among these, now the first and foremost thing that currently we would like to do is the peak systolic velocity of the middle cerebral artery using a obstetric Doppler. Okay, previously we used to do a lot of other tests, delta OD 450 and or go directly for amniocentesis. But now we have a non-invasive test which can give us a fair idea as to what is going on with the baby and how to manage the baby. Now, we do the peak systolic velocity of the middle cerebral artery. We may think of doing an amniocentesis for analysis and spectrophotometry. Ultrasound examination of the fetus, of course, we'll be doing. And if the fetal anemia on, say, on middle cerebral artery Doppler, if the fetal anemia is significantly visible, then we may think of a percutaneous umbilical cord blood sampling for HCT and RH. This is in a mother who is otherwise previously unaffected baby. Now, if the baby has been affected in the past, then there is an established sensitization. There is no two ways about it. In such a baby, we would think of doing a chordocentesis at an early stage to determine the fetal hematocrit, the RH genome. If luckily the baby is RH negative, it is sorted for us. But if the baby is RH positive and it is heading for an hematocrit less than 30, we would definitely be worried and monitor the baby more frequently. And amniocentesis, again, if required, for spectrophotometry, and initiate a middle cerebral artery Doppler in such cases at as early as 18 weeks. Okay, in previously unaffected babies, we may think of doing the middle cerebral artery little later in pregnancy, but in case of a previously affected baby, the middle cerebral artery Doppler should begin at 18 weeks and try to do it every 2 to 4 weeks to find out how much is the worsening of the situation. Now, these are just few graphic presentations of how we assess the fetal hemolysis by invasive procedures, which first and foremost is the amniocentesis, whereby we check the ODD of 450 to check the level of bilirubin in the amniotic fluid. Second is directly fetal blood sampling by chordocentesis and check the fetal hemoglobin levels, the fetal hematocrit. Now, middle cerebral artery, I am again coming back to, because this is a screening tool, which is non-invasive. It is fairly easily available to most of us. All of us don't have facilities for amniocentesis and chordocentesis, but all of us have either our own ultrasound machines or a friendly neighborhood sonologist who offers Doppler studies. And therefore, middle cerebral artery should be almost like a mainstay in screening of RH negative mothers. So, accurate and non-invasive screening tool for detecting moderate to severe fetal anemia, sensitivity of 100%, which is very good, and a false positive rate of 12%, which is fairly acceptable, and has resulted in up to 80% reduction in invasive testing. This is very important, because invasive testing, having said all about their advantages, they are invasive and they are bound to leave back side effects like infection, like triggering a premature delivery. Okay. Again, coming to middle cerebral artery, it is not very useful before 18 weeks of gestation, and therefore, in a patient who has previously affected babies, we should initiate it at 18 weeks of gestation. Okay. Not a very reliable predictor beyond 35 weeks. However, a baby whom we know is likely to be affected, we will hardly prolong the pregnancy beyond 34-35 weeks. And the results are found to be similar or even better than amniotic fluid OD 450. So it only goes to prove that being a non-invasive procedure, we can do it and it can yield better results than any invasive procedure. So this is how a normal middle cerebral artery Doppler will look. Okay. And this on the right hand, you can see the Doppler waves are so much different in a baby who is RH isoimmunized. What are the parameters that we would be looking for? A normal middle cerebral artery Doppler is a very good sign. So if it is normal, you repeat it, say every 4 weeks. Deliver the baby close to term, maybe at 32 weeks or 28 weeks, we would like to give something for lung maturity and deliver the baby at 34, 35, 36 weeks, depending on how much the Doppler worsens. And therefore, the risk of IUFD will be very low if we can, we can manage a mildly affected fetus in this fashion. Now, if we have a moderately affected fetus, that means the middle cerebral artery is 1.5 multiples of the median, that is 1.5 MOM. Then the frequency of monitoring has to be more, like every 1 or 2 weeks we would like to monitor this baby, and considered lung maturity stimulation, enhance the lung maturity by giving her injectable steroids, and deliver the baby as soon as we are fairly sure of the lung maturity in a moderately affected baby. In a severely affected baby, that is the middle cerebral artery Doppler is more than 1.55 MOM. Now, this is where we are either expecting a frank fetal hydrops or a baby who is frankly, affected. And therefore, this baby needs to be delivered as soon as possible because there's a very, very high chance of IUFD. So again, hasten the lung maturity. And in this baby, maybe we will not wait for or prolong it to close to the term and deliver this baby much faster. This is again just in a chart form, what I just mentioned. Now, suppose the middle cerebral artery shows that there is signs of fetal anemia. Okay, basically this is a predictor of fetal anemia. If the peak systolic velocity is more than 1.5 MOM or more above 1.5, then if we would think of fetal blood sampling, if the facilities are there, definitely we'll check the actual fetal hemoglobin and hematocrit, and if required, we may think of an intrauterine transfer. Okay, if fetal sampling facility not available, we can still do an amniocentesis and check for amniotic fluid bilirubin. Okay, if the middle cerebral artery peaks systolic velocity is less than 1.5 MOM, so we would just keep her monitored. We will not go for any invasive procedure. Maybe 2 weekly PSV will be done. At any time the PSV starts deteriorating, immediately we'll shift to the above column. A few words about intrauterine blood transfusion. It is definitely recommended in case of severe anemia, okay, severe hemolysis in the baby, and if the baby is remote from term, then we may think of an intrauterine blood transfusion, because often it may be the only way that we can save this baby and bring it to lung maturity. Okay, typically carried out between 18 to 35 weeks. 35 weeks is a very optimistic presentation. We will do it any fetus less than maybe 32 weeks, my personal opinion. Beyond 32 weeks, we must think about weigh the possibility of bringing the baby out. Maybe given intraperitoneally or intravascularly, depending on the expertise of the person who's performing, the facilities that are available. Typically, we will transfuse ORH negative packed cells to the baby, and the aim is to maintain the hematocrit at 80% or above. Okay, and the amount of blood to be transfused is calculated by this formula, wherein gestational age minus 20, obviously when the gestational age is beyond 20 weeks, so gestational age minus 20 multiplied by 10. That is a rough formula whereby we calculate the amount of blood that needs to be transfused into the baby. This is just a schematic presentation of how we would be doing an intrauterine blood transfusion. Postpartum management of the neonate. Now somehow we have transfused the baby and managed to keep it away from all the effects of hydrops, and maybe at 34, 32, 35 weeks, as how it has permitted, we have brought this baby out. If the baby is brought out alive, it has to be admitted to NICU. There are no two ways about it. May require an urgent exchange blood transfusion, okay, especially if in a moderate to severely affected neonate, we may require to give, I think I'm exceeding my time. So anyway, this is among the last few slides. Urgent blood transfusion is indicated in moderate to severely affected neonates, and phototherapy in mild affection. Okay. What are the special fetomaternal risk states? Already we've been through that there is a chance of, in case of an early abortion, the mother has some chance of immunization. So 50 microgram of the anti-D is indicated. If 50 not available, maybe 150 microgram can be given. Any invasive fetal procedure like amniocentesis, chordocentesis will require a dose of 300 microgram. Antepartum hemorrhage, any kind of antepartum hemorrhage, if there is a history, the 300 microgram to be given, stat to be repeated 12 weeks later if the pregnancy goes beyond that. Any kind of procedure like an external cephalic version block, thankfully we don't do it anymore. Okay. About antenatal anti-D, there are proponents of and giving antenatal anti-D. So if we must give it, now there are two regimens that are there. One is giving antenatally at 28 weeks, then repeating at 34 to 36 weeks, and then the third dose after birth. And the other regimen is the single dose antenatal and single dose postnatal. So total 2 doses versus 3 dose regimen. And they have found that the 2 dose regimen gives equally good results to 3 dose regimen. And therefore, in a resource poor country like ours, I think if we must give an antenatal dose, then we should stick to the total 2 dose regimen. That is anti-D 300 microgram at 28 weeks of gestation, and to be given after birth, obviously after checking the baby's RH test status. Okay, so this more or less covers. Okay, what are the newer advances? Just to complete the list, there's now non-invasive fetal RHD genotyping that is coming in a big way. Point to care test. Okay, so these are rapid tests for determining the RH status of the baby. So if we know this in advance, it will help us a lot in managing RH negative mothers. Lower dose of 50 microgram dose preparations that of anti-D that are coming in for first trimester, and the concept of partial D and weak D antigens. So usually they are D positive, but these are the previously considered weak antigens, but they can also potentially produce the antibody. So the take-home points after this exhaustive presentation is: number one, every woman of the childbearing age who comes to you for first contact should get her RH and ABO typing done. Okay. If she is RH negative, then we get her ABO and RH type of her husband as well. Single hemorrhage, so we may consider one dose at 28 weeks and the next dose after delivery. High cost of what are the problems that we face in our resource poor country is obviously the high cost of immunoglobulin. That's why I discussed that if at all we have to give antenatally, maybe 2 doses, one at 28 weeks and one postnatally should do. Lack of resources to investigate, especially the invasive investigation may not be easily available to us, and poor documentation and poor case notes is one of the important, it riddles our society, and therefore making any recommendations based on our population study becomes very, very limited. Okay. So in conclusion, RH is a real problem and we need real efforts to mitigate its impact. Its incidence has definitely dramatically decreased, yet it is there to stay with us, and the consequences of hemolytic disease to the newborn remain, and they remain to be horrible. Great advances have been made in detection and management of these conditions, and many of our RH negative mothers can now have a very, very happy and long obstetric career. Does not mean I'm recommending a long obstetric career. Okay, and I began with a picture, a photograph from Amar Akbar Anthony. So let me end with Amar Akbar Anthony. So whenever Bollywood gives us lemons, they throw lemons at us, the doctors make lemonade. And therefore, I'm utilizing this very same picture with some silly transfusion habits shown in that picture to recommend that all of us donate blood and save life. So thank you to the chairpersons, Dr. Kiran, Dr. Ameya. Thanks to Pratik, to my co-speaker Sonia ma'am, and to the entire audience for giving me a patient listening. And if there are any shortcomings, please do forgive me. And I think I'll now stop my slide share and hand over to the MOC. Thank you so much.
Thank you, Dr. Supriya, for that exhaustive but highly informative lecture. I think you have emphasized through the various aspects of modern management of RH isoimmunization, which has shown the following changes in the management. First of all, we are extremely happy to note that the preventive aspect by giving antenatal anti-D, not just postnatal anti-D, has significantly reduced the risk of isoimmunization. So it is now well accepted that antenatal anti-D, not just postnatal anti-D, is now an accepted standard of care part of management. Number two, from amniocentesis, which was an invasive method, we have now moved on to using MCA PSV as a non-invasive method, thereby improving outcomes, at the same time not compromising, in fact increasing the early pickup of outcomes. And number three is that with advances in neonatal care, we have been able to ensure that not just intrauterine transfusion, but even extrauterine care of these babies have improved the outcome. We are seeing lesser and lesser cases of kernicterus and other problems. I think one important point that we need to keep in mind is that as our focus remains on RH isoimmunization, we must not forget that there could be isoimmunization also because of ABO incompatibility, though it is less severe, thankfully, and also of the rarer blood groups, which a small minority of our population do suffer from. So all these points have seen that there has been a drastic change, and we are happy to note that we are offering better outcomes to these complicated pregnancies. Also, with the advancement in fetal medicine, intrauterine transfusion is more widely performed, more skillfully performed, with better outcomes to the baby. So thank you so much. We'll move on to the next talk. And could we have the biodata of the next speaker? So it gives me great pleasure to invite one of the most well-respected and senior members of the OB/GYN fraternity from north of India, namely from Delhi, Dr. Sonia Malik. Dr. Sonia Malik is the director and HOD of the Nova South End Fertility and IVF Center. She has been the past president of the Indian Fertility Society. She is the chair of the Infertility Committee of FOXI from 2014 to 2016, has also been the past president of the Indian Menopause Society in 2007-2008. Dr. Malik is known for her academic pursuits and her academic prowess, and has been the associate editor of the Southeast Asia wing of the Journal of Global Health of the IFFS. She is the member of the editorial board of Fertility Sterility India, and also the member of the editorial board of the Journal of Reproductive Health and Medicine and the Journal of Fertility Science and Research. Dr. Malik has been the past editor-in-chief of the Journal of Midlife Health as well, and has been keenly involved in research with respect to reproductive health and medicine, and has been the scientific collaborator of the Reproductive Research Center, Cleveland, USA, and a member of the ICMR task force on genital tuberculosis. In fact, to put it short, if there is someone who is the authority on genital tuberculosis in India, Dr. Sonia Malik undoubtedly will be the person who we will go to. It's a great pleasure to have you in this AMOX platform, Sonia ma'am, and over to you. We are all eager to listen from you in your talk over the next half an hour.
Well, thank you so much, all of you. Thank you, AMOX, for having me over here and giving me this opportunity to travel to Maharashtra and be with you all for this seminar. And thank you so much, Amey and Pratik, and of course, Dr. Kiran, whom I can't see here. And the speaker before me, Supriya, was excellent. She spoke extremely well on a subject which I do not know much about. So I'm so glad I attended it and learned a little from you. Thank you, Supriya. Thank you. So my topic today, I have been asked to speak on tuberculosis, as was said. But interestingly, the subject that Pratik has given to me is different. I'm going to be talking about recurrent implantation failure with female genital tuberculosis. So a subject which is less talked about, and let us see if we can really gather some evidence to support what I'm trying to say to you, and really prove or say, maybe try to say that it does exist. So therefore, let us first try and define what recurrent implantation failure means. And as you can see here from this slide, which is quite busy, you can see that over the years, various people have given different definitions for recurrent implantation failure. However, in whatever we know today, it just means that the HCG level is not rising and you cannot see a gestational sac. So in other words, a biochemical pregnancy or a pregnancy that is not doing so well is actually defined as recurrent implantation failure. And the most popular definition was given by Colehan in 2014, which seemed to be a little more complete, where a failure of clinical pregnancy after 4 good quality embryo transfers with at least 3 fresh or frozen embryos IVF cycles, and in women under the age of 40 was what was defined as recurrent failure. So what causes it? So we all know that it is the embryo and the endometrium, but mostly now we are more concerned about the endometrial embryo synchrony, or as we call it in layman's term, the maternal embryo crosstalk. So this is actually the most important factor. They have to support each other in order to have a proper pregnancy. And therefore, the relative contribution of the embryo and the uterine receptivity is the tune of 45 to 55%, as was said. The reference is missing here, but it was Walters in 1985 who suggested this. However, now we know that it is the embryo quality which is becoming more important, as we have methods to detect the good embryos and the bad embryos. So how does implantation occur then? In mammalian gestation, the immunological acceptance and tolerance are very, very important to have a proper implantation at the embryonics, at the site in the uterus. And basically, what happens is, it is the semi-permeable zona pellucida which forms post-fertilization, and this actually protects the embryo until it reaches the endometrium. And then the zona is surrounded by the maternal immune cell, and this entire unit actually transmits the message that fertilization has occurred. This is very important, that it is actually, the message is passed on by the embryo to the endometrium that it is now coming, and therefore it needs to be accepted. So therefore, but the problem is that in IVF and embryo transfer, this mechanism is not operative, but it is said that the culture mediums does stimulate early pregnancy factors, and hence it helps in implantation. So therefore, now, like I said, the role from the endometrium is kind of shifting to the embryo, which is the most dominant element in the reproductive process, and its viability and ability to signal are actually critical for embryo-maternal dialogue. But nevertheless, we cannot forget that there are markers of uterine receptivity which are actually telling us that the blastocyst is approaching the endometrium, and hence the endometrium should prepare for it. So the different kinds of markers that we have been classifying are the signaling markers, which tell us that the blastocyst is approaching the endometrium, the classical markers which are required for apposition, attachment, and invasion, and then some molecules which are involved in the cellular differentiation and mitogenesis, which is required for the survival of the embryo in that particular milieu. So therefore, these markers are actually coming one after the other during the luteal phase in the endometrium, and then this is what is making the endometrium receptive for the incoming embryo. And so what happens is, we have actually been able to define various kinds of markers, and hence what is important is that it acts as a mechanical barrier. There is suppression of maternal immune system. There is a local immune suppression as well. And we know that there is a type 2 dominance over there, which is actually responsible for the embryo to implant. But then what is the latest recognition is that there is something called an early pregnancy factor and a pre-implantation factor, which are also stimulated or functional as soon as the zona pellucida tries to reach the endometrium. So basically, it is this which acts as the first stimulus probably, which is going to direct the embryo towards implantation. However, we also have learned some lessons from these two major areas of science. One is the contraception, where we have given the progesterone only pill, and the second is the donor recipient cycle. These two areas have actually made us know that no matter how good the embryo may be, if the endometrium is not good, say after a progesterone pill, then it's not going to implant. Similarly, if in a donor recipient cycle, which we are preparing sometimes for the postmenopausal women as well, if the endometrium is not well prepared, the embryo doesn't implant. So we cannot say that it is entirely the embryo, therefore, that is responsible for pregnancy, but it is also the endometrium which is equally important, or the milieu which is equally important. And we have had these pregnancies without the ovaries also, where it has kind of proven that the endometrium has a large role to play. The donor egg program has served as a model, and it has told us what the estrogen and progesterone actually do and what immune modulation takes place at that level, which gives rise to a healthy pregnancy and implantation. And recently we now have the endometrial receptivity array, which actually boils down to the gene expression which happens at implantation and in a natural cycle and in a hormone replacement cycle. There we find that there is, after the LH surge, we find that there is endometrial receptivity happening over there because of the changes that are taking place in the endometrium. So we cannot rule out that the endometrium is bald when it is not receptive, and gradually we have these spinopodes growing over there, and it becomes a lush carpet-like area when it is ready to receive the blastocyst. So we just cannot say that we have to only study the egg, we also have to study the uterus. So coming to that, therefore, we have inferred that there are certain conditions where the endometrium is poor or the receptivity is poor, and out of them we have chronic infections. That is what we are going to talk about now in greater detail. We all know, and this is a slide showing you how the coronavirus enters the body of the human and how it affects the immunology and the molecular environment of the host. And it's in this last year, 2020, we have learned a lot about immunology, I would say, and we can actually apply that to what we are going to talk about now. So let us just try and understand how the immune system functions when it is being faced by a microorganism. We have these two immunities, the innate immunity and the adaptive immunity. The innate is non-specific, and the adaptive, as you all know, is specific, and it has a memory. So therefore, it is cell-mediated and humoral both. Even the innate is such. However, the infectious agent, whenever it is presented, then there is activation of the innate immunity and finally activation of the specific immunity. The components of the innate immunity at the cellular level are the monocytes and these cells, as well as the complement and the acute phase proteins. However, the adaptive immunity is actually represented by the T and B cells and the antibodies. So what happens is that there is the T cells which are activated, and the primary T cell is activated in adaptive immunity, and gradually then it changes either to the Th1 or the Th2 cell, depending upon what kind of response the organization or the organism is going to face and the human is going to replicate. So what happens when the extracellular microorganisms enter a body? It is just encapsulated and phagocytosed by the macrophages, and it goes inside the cell. Whereas if the organism is encapsulated, then there is a slight problem in trying to kill it. And therefore, there is the formation of the antibodies, which kind of engulf it, and finally it is phagocytosed and it goes. It may even kill the cell or the macrophage. What happens then to organisms which are in addition to that, in addition to the antibody, there is also the activation of T-specific cells, which relieves cytokines, as we all know now. And these activated killer macrophages, which are actually having these activated cytokines, engulf the organism. It is taken inside, and then taken care of. So therefore, there is a complex mechanism wherein the microorganism is actually tackled by the cell, by the human cells. So the survival of an infective agent, if it is an extracellular organism, is if the host response and antibody formation is compromised. And in an intracellular organism, if the antibody formation is compromised or the activation of the T cell response is also inadequate or deficient. So in such circumstances, the infective agent will survive. What then happens in a chronic infection? In a chronic infection, you will actually end up as having a chronic infection if the organism can adapt itself and its metabolism to survive within the body of the host, number one. Number two, if it can modulate the immune system of the host. And number three, if the immune system itself is deranged and cannot eliminate the organism. So under these three circumstances, the organism will go into a state of chronic infection. So therefore, we have to understand what is exactly tuberculosis, how does tuberculosis really survive inside. So what are the factors, therefore, that affect this immune regulation? Look at the huge number of factors that we have. And actually, much of it is also dependent upon the type of organism that is affecting us, the pathogenic strain and the pathogenic load. However, our own system, that is the endocrinology, the cytokine profile, that means the antibodies that we can form, the route of infection, previous infection, and other genital infections are also going to take care of what is going to be the response of the human being later on to this organism. And we are basically in reproduction, in infertility and fertility, involved with the endocrinology and what is the effect of our endocrine system upon the infections is what we are concerned about. So how does it regulate the immune response? How does our hormones, the estrogen and progesterone, how do they regulate the immune response? So as I told you, there is a the TH cytokines, which are all actually a function of the thymus gland. They are actually secreted. And if the estrogen is low and we have a high prolactin, it is actually favoring a TH1 response. However, if there is a high estrogen and progesterone, as we find in pregnancy, it favors a TH2 response, which is helping the pregnancy to go on. So this leads to a dominance of cellular immunity, and this leads to a dominance of humoral immunity. What we need to understand is that this is going to help this is a pro-inflammatory state, and this is an anti-inflammatory state. Therefore, pregnancy can carry on well. So hence, it is important for the hormones also to be normal in order to have a proper immune response. Some of this is very well seen in the female genital tract, and it has been seen in experiments that during the entire menstrual cycle, the epithelial cells, the macrophages, dendritic cells, NK cells, and neutrophils function to meet the challenges of infection, while at the same time, they are supporting an immunologically distinct fetal placental unit. So therefore, all these cells are doing a dual function, one, to support the fetus, and second, to prevent the infection from happening. And it is the estradiol secreted by the ovary during the menstrual cycle, which is actually causing all these immune responses. And so if you can see the hormonal effects of the various hormones on the immune system, you can see over here that estrogen performs a huge function by actually acting upon the immune cells, and so also progesterone and testosterone. Now, this is a beautiful paper which came out in 2007. It is a review paper which actually tells you of the effect of estrogen on each of these immune cells, whether it is the antibody TNF alpha or interferon gamma or IL-1 or the mast cells or the NK cells. It tells you what happens to them as the level of estrogen increases in pregnancy. And that is what is going to give rise to what is happening to your body or the body of the patient when she is becoming pregnant. And so the function, the influence of estrogen on the T cells depends upon the level of estrogen and its effect on the naive thymic cell, that is the T cell, and finally, what kind of immune response it is going to generate in the human body. So therefore, this immune modulation, this intense immune modulation, which is taking place inside the woman's body, has a dual function. One, it helps to create a anti-inflammatory state. It doesn't promote inflammation. And second, it protects the human body from infections. A very interesting phenomenon, a very interesting experiment was done to understand when this happens maximally in a menstrual cycle. When is the immune system most downregulated? And what they found was, it was from day 21 to 26 that the immunity of the woman is completely low because of the high level of progesterone. And that is the window of vulnerability when the HIV infects the woman maximally. And this can actually be replicated to tuberculosis as well, because this intracellular organisms acts much like the viruses, and therefore it functions very much like that and gets stimulated as soon as it finds that the immune system of the woman is weakened. So therefore, a Th1 cytokine response will favor an abortion, and a normal pregnancy generally happens if there is a Th2 cytokine response. And you can see here that the ones that we want are the IL-10, IL-9. These are the ones which should be upregulated in order to have a good response. So then coming back to our main subject of tuberculosis and how it affects the immune regulation, what it does to the uterus as well as the ovary. We all know that it does decrease the pregnancy. This has been known as early as 24, that tuberculosis can decrease the fertility and give rise to infertility. And this paper also says that it is, it just keeps on lying inside our body insidiously, and therefore the organism has to be always taken care of. So basically, this was a paper which was in 1996. This was an oration by Dr. Wadia, from, you know him well, from Mumbai. And he was very perplexed because he found that there are two kinds of patients that he was seeing, the ones who are presenting with infertility and the ones he found on laparoscopy who had come for tubal ligation. They also had the same findings as these patients who were infertile. And that was a very big complex situation for all of them at that time, because this function of immunology was unknown to us at that time. So therefore, any condition that disturbs this immune function renders the creature sterile. And it was only in the middle of 20th century, sterility was said to be caused by when either the formation of gametes was disturbed or the transportation was disturbed. We did not know anything else about infertility and sterility. And now we know that there is an interplay of all these systems, anatomy, physiology, and immunology, and the molecular changes which are taking place, which actually are giving rise to this kind of state. So tuberculosis exists in 3 states, as we all know. In 1998, WHO said that tubercular disease, tubercular infection, and reactivation of disease can happen. An active case is basically disease, and a latent infection is when there is an infection there, but it is not presenting as active infection. And this latent infection can get activated, that which is called reactivation of disease. However, as we got into the life history of MTB, we understand that gradually when the baby is born, it has no adaptive immunity, but however, there are antibodies passed on by the mother, and finally, these are carried on to the child. But most importantly, what we discovered was that active tuberculosis exists only in 10% of the infected individuals, and generally asymptomatic latent persisting infection is found in most of the individuals. And actually, it is the normal host defense and antimycobacterial drugs which help to convert the bacilli into the inert form, and therefore we have most of the patients presenting as latent tuberculosis. The course of the disease will depend upon the host organism interaction, the virulence of the organism, and the immune response. If it is a very virulent strain and the immune response is small, then there is a spread of disease with caseation, etc. However, if the patient has a very good immune response, either there will be only increased immune modulators, or granuloma formation or lymphocytic reaction, nothing more than that. So this is basically representing the latent disease. A very recent paper in 2014 from Flynn and Chan. I'm sorry I haven't written the names over here, but this is a paper which you all must read. This actually tells you that tuberculosis, very much like HIV, depends upon the immune system and immune modulation that keeps on happening in the lifetime of the individual. It is not just 1 month or 2 months. This actually keeps on happening. And these are the various stages of the disease or the spectrum of response, which is as a result of the bacterial load. So if the bacterial load is much, it will manifest as disease. And if it is just very, very low, then basically the immune response is actually going to eradicate it or absolutely eliminate it. This is very important because this has a bearing on the kind of tests that we are doing, and I shall come to it soon. So the effect of GTB on reproductive organ is blockage of tubes, loss of tubal function, perisalpingitis, defective ovarian function due to tubo-ovarian mass formation, adhesions, anovulation, and poor ovarian reserve, and the endometrial damage due to the TR endometrium with adhesions and poor receptivity due to release of interleukins, etc., and disturbance of the endocrine balance. So the involvement of different organs is variable, and as far back as 1998, Dr. Tripathi told us that 90 to 100% of cases will have tubal involvement. The uterus is involved in about 50 to 60%, ovaries in 20 to 30%, and cervix, interestingly, from only 5 to 10%. So the effect on the ovary, now we need to understand how implantation failure is taking place. So the effect on the ovary could be the morphological changes in the ovary or the functional changes in the ovary. And indirectly also, the ovary would be affected because of the tubes, because of the hydrosalpinges, the anatomy of the tube, as well as the adhesions around it, and the effect of the fluid of the hydrosalpinges. The impact will also be on the endocrine ovarian function, and the impact will also be on the oocyte quality. So all these changes, whether they are directly happening in the ovary itself or they are happening in the tube, are going to affect the ovary and the function of the ovary. So first few papers came out very recently, and this paper is from All India Institute by Neena Malhotra, where the effect of tuberculosis on ovarian reserve was seen in women undergoing IVF in India. And very recently, Padmarekha Jirge and her group in 2018 published the first paper, which talks about decreased ovarian reserve in infertile women in latent tuberculosis. So gradually we are learning that ovarian reserve is actually hit by tuberculosis, and oophorytis actually can cause a decrease in ovarian reserve, but the exact cause, how it is happening, is not known. It is possible that it is because of the inflammation and scarring that it leads to disfigurement and actually cause a problem with the function of the ovary. So what are the effects then on the hormones? Because of this oophorytis, the disease may deplete the ovarian reserve. Similarly, pulmonary tuberculosis has been shown to result in hypogonadotrophic state due to associated cachexia and inflammatory milieu. This results in a secondary ovarian failure. And high gonadotrophin levels have also been seen in some patients who are on ATT due to the anti-estrogenic effect of rifampicin on the P450 enzyme system. This has been observed particularly in patients who are taking birth control pills. There are 2 reports which suggest this, where the efficacy of the pill was decreased leading to a failure of contraception because of a relative estrogen deficiency, which was caused by the tuberculosis. So therefore, whether it is through the ovary, whether it is through the pituitary ovarian axis, or whether it is because of the effect on the estrogen itself, you can understand that it does affect the hormone function. And this is something that you have to keep in mind when you're preparing the endometrium of the patient, and you find that there is a thin endometrium. Sometimes it may not be because the endometrium is not responsive. It could also be because the estrogen is the disease causes an estrogen deficiency in the system. We also know that there is a poor ovarian response when these patients are stimulated. They require more gonadotrophins. They produce poor quality oocytes, poor quality embryos, and poor endometrium, leading to low implantation rates and pregnancy rate. This is an observation of all the IVF specialists, although there are not too many reports on this, but this is what is seen in all the people who are practicing IVF in tubercular patients. The first paper that I came across was from Dr. Kuldeep Jain's unit in 2018, which it is a short paper of 28 patients, where he found that the oocyte quality is definitely affected and the ICSI outcome in these patients is poor as compared to controls. Way back in 2003, I wrote this review on the implantation failure in genital tuberculosis, and basically I emphasized basically on the immune modulation aspect. The endocrine, it acts as an endocrine disruptor, and actually it stimulates the formation of APL antibodies because it's an infection, and therefore that also leads to failure of implantation. So there have been reports which suggest that it is an endocrine disruptor. All these reports initially came from Russia. And this report was in 1989, which said that it causes glandular hyperplasia on histopathology. And then this report was again from 1997 from All India Institute of Medical Sciences, where in the physiology department, they demonstrated the antigonadotrophic effects on MTB. Basically, it inhibits the basal production of progesterone and the stimulatory effect of HCG. Therefore, tuberculosis could cause LPD and lead to failure of implantation. This was a very nice paper, and we do understand and we do know that these patients require a lot of progesterone support in the luteal phase if we have to achieve pregnancy. So it has also been noted that in patients of MTB undergoing IVF, there is high basal FSH levels. They are actually poor responders and they require lots of gonadotrophins. How about immune modulation? The reactivation of the disease takes place as soon as we try to attempt a pregnancy. There are no trials available, but reports are available. The first report came from Turkey, and then there was this very interesting report in Human Reproduction in 1995 from Israel. So basically, all of these reports suggest that there is an iatrogenic provocation of genital tuberculosis as soon as you try to make them pregnant. And this report also suggests the same thing, that miliary tuberculosis was initiated as soon as IVF was tried. So it is very, very important to maintain this and the balance, the Th1, Th2 balance, in order to have a normal pregnancy outcome. And taking a cue from this report of Raghupati et al. Actually, it is this report, and it is this group from Kuwait who actually told us all in the world the importance of the Th1 and Th2 balance in case of pregnancy and pregnancy loss. And taking a cue from them, I tried to understand the cytokine profile of the endometrium in such patients, and we presented this paper way back in 2004, where we looked at the endocrine profile of the cytokine profile of different groups of patients, the infertile patients versus the recurrent aborters. And interestingly, we found that in the recurrent aborters, the inflammatory markers were much less as compared to the infertility group, where we found a very high positivity of TNF-alpha and interferon gamma in the endometrium. And then we did we published this study in this book by Mala Arora, where it was a short study of 86 patients where we tried to see the effect of tuberculosis on the recurrent abortion. And interestingly, we found that after treatment, there was 41.6% of these patients who were recurrent aborters went on to having a term pregnancy. Only 8.4 ended up in an abortion, but there were still some patients who still remained positive after even 9 months of treatment. And that part I shall address a little later. And of course, there were about 11% who were even infertile after treatment. So basically, we just did this small study on recurrent pregnancy loss. However, I have not done implantation failure till now. Effect on the endometrial function as such. You all know, and we all know, that PCR has been the bone of contention, and it has actually caused a lot of confusion as far as we are concerned in the treatment and management of genital tuberculosis. But we have been looking at it, and now it is being substantiated by the immunochemistry for MTB. And one large study has been done from All India Institute, where they have looked at plasma CD138 and supplemented it with PCR and found that, yes, the tubercular endometritis is also very, very common, because chronic inflammation, plasma cell CD138 cytokine is an indicator of chronic infection. So all these tests put together are definitely now helping us to understand what is happening to the endometrium. However, many people from our groups in India have looked at the endometrium before and after ATT, and they have found that there is a marked difference in the receptivity of the endometrium or the receptivity of the uterus after giving ATT. The active disease in the form of Asherman syndrome is known to so many of us, and we have seen even these suppurative or this pus-like thing in the uterus of these patients, as well as the adhesions, as we know, on HST. So basically, hysteroscopic patients we all know, but what we need to understand is that these dormant can always become active at given in various situations, and basically it all depends on the resistance of the host, the compromised immunity. Most importantly, it is the compromised immunity which interests us. It is pregnancy or our attempt to make a patient pregnant which can lead to this kind of a situation. And reactivation could be genetic, could be an infertile pregnant patient whom we are trying to make pregnant, a surgical manipulation like laparoscopy, hysteroscopy, and pelvic surgery, a high steroid levels that we initiate in IVF can increase the vascularity during ovarian stimulation and could be a triggering factor. Empirical use of steroids and immunotherapies, which we are rampantly using these days at adjuvants, can also stimulate or activate tuberculosis. And immunocompromise always, as we all know, can lead to activation of tuberculosis in HIV patients. So the effect on endometrial receptivity, endometrial markers, is actually adverse, and there is also a defective vascularization of the endometrium, and this, as I mentioned earlier, could lead to activation of antiphospholipid antibodies in the endometrium. It reduces the subendometrial blood flow, and of course the endometrial immunomodulation is affected, thereby giving rise to a hostile endometrium, and then thus a failure of implantation. On ultrasonography, we can see it. A hostile endometrium can be seen as minor endometritis, which is seen as thin, irregular, or broken endometrium, or we can see calcific spots or even big pieces or adhesions over there, which indicate that the endometrium is not good. And this is something that I mentioned to you just now, CD138. 25% of these patients of infertility with chronic endometritis would have these positive and scattered in the endometrium. And as you all know, chronic endometritis is now the big buzzword in the field of ART, and we all know that we have to rule it out before we progress. The biochemical markers this is from Dr. B.N. Chakravarti's unit. They have looked at the biochemical markers in cases of tuberculosis, and they have actually looked at mucin 1, integrins, LIF, cadherin, and MECA in such patients, and they have found that all of them are much reduced and thereby reducing the endometrial receptivity of these patients, and hence leading to a hostile endometrium. Also, they have looked at the pinopodes, and they have found that the pinopodes in these patients, look at these endometria on microscopic examination, they have found that basically they are not well developed in cases of even latent tuberculosis. So they took latent tuberculosis and they took controls, and they found that most of them had poorly developed pinopodes. So it does show, this is an electron microscopy study, which is not possible in all units. However, it does indicate that the tuberculosis does affect the endometrium. So therefore, Dr. Neena Malhotra again aims, the same group looked at the endometrial blood flow, and they found that the perifollicular blood flow in such patients was also poor. And this told us that the genital tuberculosis is not only affecting the cellular type of the endometrium, but also the blood flow to the endometrium, hence decreasing the possibility of pregnancy in such patients. But however, our problems now are, we know that there is a problem with the eggs, we know that there is a problem with the endometrium, but our biggest problem is that there is a diagnostic dilemma. We do not know how to prove that this patient has endometrial tuberculosis, because we do not have clear-cut criteria in monitoring the treatment. And of course, there is a compliance of the patient, but interestingly for all of us, the patients are quite compliant and they do listen to us, because infertility is a big thing in their lives. But of course, we have to keep in mind the toxicity of the drug and do not use it rampantly, because it can cause harm to the patient. Hence, it is now the most important thing that we need to understand is how to diagnose it. And therefore, I come back to the same slide that I showed you. And interestingly for you, it is interesting for us to understand when the patient is having a quiescent infection, PCR is going to be positive. When the patient is going to have an active infection, also PCR is going to be positive. And when the patient is having a clinical disease, PCR is going to be positive. However, we need to treat this patient only when these two are, when she has active disease and when there is a clinical disease. In case of a quiescent disease, it is all right. It doesn't really matter because it's not going to affect us. Therefore, is PCR true or false is a big problem for us. Is it a live or dormant bacteria is something that we've been always bothered about, and should we treat it or not is something that we have to bother about. However, from all the slides and from all the literature that I have showed you, it does help. It does mean that, we have to be wary of this infection also, because if the host is immunocompromised at any given state, this quiescent infection can actually become activated. So we are really treading on fire, and therefore we have to be very, very careful when we are treating our patients and making them go through IVF. So the recommendation from the Index TB guidelines, which were given out by the Government of India in 2016, states that there are no firm answers, but today patients are not to be put on treatment on the sole basis of PCR, and there has to be an additional proof either in the history or the physical findings and other investigations, which will tell you that this patient is having tuberculosis, and only then the patient has to be put through anti-tubercular treatment. So with that now, of course, we are coming to some kind of clarity. However, it is very reassuring to see that the effect of treatment, if we are able to really pinpoint and say that this patient has tuberculosis, then it is very good. So this treatment, these 3-4 reports are in the at that point of time when there was a lot of controversy about PCR, and some people believed in it. And this was again the first report from Dr. Chakravarti's unit, which actually is the only report on repeated IVF failure or recurrent implantation failure in the Indian setting. And way back in 2006, they studied and found that after treating these patients, the result was better. And of course, Dr. Jindal from Chandigarh also found a favorable outcome after giving anti-tubercular treatment to her patients. Similarly, this is a study again from All India Institute, where they found that the infertile women and infertility outcome was much better after treatment. At the same time, we also presented our paper in 2007 of 200 patients of infertility, where we considered it positive only when there were 2 more indicators along with the PCR positive. For instance, something in the history, something in the findings, in addition to the PCR, and they were put on WHO regime. At that time, we were using 9 months, not 6 months, and the spontaneous pregnancy was 27%, IUI was done in 11%, and 27% after IVF and ICSI. So this is the outcome of treatment of various groups published from India and over a period of time. And as you can see over here, that the pregnancy rates, IVF pregnancy in 1997 was 16.6%. I will show you that here it is improved to 29.2% because the method of diagnosis has changed. Here they were actually looking at only, this is Dr. Feroza Parikh's paper, where it was not PCR, it was laparoscopy. And Here, it is PCR along with laparoscopy and hysteroscopy and ART. This is Dr. Jindal. And again, Dr. Chakravarti's units using PCR as well as biopsies. So basically, it also depends on the type of diagnostic tool that has been used, how early the pregnancy has been, how early tuberculosis has been detected. All that has an implication, and all that actually affects our pregnancy rates. And this is the result of ART in tuberculosis all across the world. These are the various reports that have been published across the world. And as you can see here, in most of these earlier reports, the tuberculosis was detected quite late, and when the granuloma formations were there, or there was histological evidence of tuberculosis. However, when we started working, this is my own report of 2010, when we all started working, we were relying on PCR, and therefore the results definitely have improved after we have become more conscious of tuberculosis, and we have started to know the nuances of this disease much better, about immune modulation, etc. We also have used third-party reproduction, as we all know, oocyte donation and surrogacy. But again, the reports are saying that it is not very, very good, although, of course, there are lots of indications, as we all know, of surrogacy and tuberculosis. But again, not very, very good. So therefore, it can cause recurrent implantation and IVF failure due to its overt anatomical effects on the reproductive system, as well as its latent effects on the physiology and immunology of the person, affecting both the oocytes and the uterus. And therefore, we have to be really, really vigilant and careful about the presence of tuberculosis, especially when we are faced with a patient of unexplained recurrent pregnancy loss. In such patients, it is important, it is, I think, mandatory now to look for tuberculosis wherever you can and then treat her. So with that, I thank you very much for being here with me. And I hope I have been able to convey something to all of you. Thank you so much.
May I please unmute?
Thank you, Dr. Malik, for that excellently put forward, highly researched, and very, very important presentation, especially in the Indian scenario, because how much ever we try to deny or shirk the fact, genital tuberculosis is an enigma, and especially importantly addressed by you in infertility. And it's a challenge, but I think with better understanding, better diagnosis, and a vigilant approach, we'll be able to manage these patients better and give them a favorable pregnancy outcome. So thank you so much.
Thank you.
It was really an highly informative and an enlightening talk.
Thank you very much.
So I've been informed that there are no audience questions. We had two stunning speakers today. I think all the queries or doubts that the audience might have had, there are about 375 logins today, which is an excellent audience for a weekday afternoon. So congratulations to both the wonderful speakers. I think you were fantastic and elaborate, highly appreciated by everybody. And there are a lot of appreciative comments and congratulations which have come in the chat box. So we thank the audience also for being there. Any closing remarks before we present the vote of thanks?
Once again, I would like to thank Dr. Pratik Tambe for an excellent organization of these webinars. I think it's really bridging Bharat, and especially the AMOX platform, by having our regional experts as well as national experts talk on very important, pertinent and practical aspects of contemporary management. I think these are very well appreciated, and I think will be beneficial in day-to-day practice. So thank you so much, Pratik, for the excellent choice of topics and the excellent choice of eminent speakers.
Thank you very much, sir.
Thank you very much for having me here. Thank you very much for this opportunity. Thank you so much.
It's lovely to
Thank you
have
so much,
you with
Pratik.
us.
And Ameya, Kiran, and it's a real honor to share the stage with Sonia ma'am. Ma'am, your presentation was really fantastic. So thank you, Pratik, for putting me with madam for this lecture. Thank you so much.
And thank you for enlightening me. I didn't know so much about it. Thank you.
Thank you, ma'am. And Pratik, if with your permission, I would like to say one goodbye shairi.
Yes, please go ahead.
चिरागों को दिल में जलाए रखना, because these are COVID times and we don't get the chance to meet in person for so many days now, and we don't know how the future holds for itself. So चिरागों को दिल में जलाए रखना, बहुत दूर तक रात होगी, मुसाफिर है तुम भी, मुसाफिर है हम भी, किसी मोड़ पर फिर मुलाकात होगी, किसी मोड़ पर फिर मुलाकात होगी. So let's
Lovely.
hope to
Thank
see
you.
better
Thank
days
you.
and meeting
Thank
in
you.
person.
Yes,
Thank you, ma'am.
Lovely.
Thank you so much. Thank you
So
so
my
much.
pleasant task to present the official vote of thanks as the convener for today's event. I'd like to express my gratitude to our dynamic president, Dr. Nandita Palshetkar, our secretary of AMOX, Dr. Arun Nayak, two wonderful chairpersons, Dr. Kiran Kurtakoti and Dr. Ame Purandare. Thank you so much for taking time out from your busy schedule and being here right till the end, Dr. Ame. And two stalwart speakers, Dr. Supriya Arwari, who is the chair of the Adolescent Health Committee of AMOGS, and Dr. Sonia Malik, our past president of IFS, for enlightening us on two key issues in OBGYN. We are nearly 375 audience who had logged in throughout the length and breadth of the country. Thank you very much to our academic partners, Bharat Serums and Vaccines, for the educational grant, the Feminora division. Thank you for the Bridging Bharat initiative, and to Science Integra, our scientific backbone, Subbu, Shrimon, Session. Thank you so much for always being there in the background, for supporting us and encouraging us in this entire series of events that we've been doing with the AMOGS Endocrinology Committee. We hope to see all of you very soon in the near future. Till then, goodbye, God bless, and take care. Bye for now.
Bye-bye,
Thank
take
you.
care, and thank you, Pratik,
Thank
for
you.
your extreme hard work. Thank you so much.
Thank you, Dr.